Thank you for joining me for this episode. I'm Dr. David Kading, and today I'm joined by Dr. Natalie Noble. We're going to be speaking about GLP-1 and your diabetic patients on the OI show. Are you finding that being a business owner in optometry is getting tougher and tougher every single year? Here's the tough truth. For every hour that we spend with patients, we spend 2 hours on administrative work, from charting, working with our team for prior authorizations, inbox messages, and so forth. In fact, up to 70% of our team's time is non-clinical, and patients are feeling this disconnect. I've worked with virtual staffing for over 10 years, and when we started implementing virtual team members into our practice, it changed everything. And then when we found team, everything changed. They helped us choose and support the right people. Now a virtual team handles documentation, prior authorizations, patient communication, phone calls, and scheduling. For more times with your patients, more energy for your team, visit hireteam.com. That's HIRETEEM.com, hireteam.com to get you back in your practice in 2026. Thanks again for joining me for this episode. I'm delighted to be joined by Dr. Natalie Noble. It's a pleasure to get to have you on the podcast. Thank you for joining me.
Yeah, thanks for having me.
Yeah. So, Dr. Noble, tell us a little bit about your background, optometry school, what you've been doing in practice over the last number of years.
Okay, so I am a fourth generation optometrist. I went to school at NECO um, and came out and sort of inherited my grandfather's keratoconus practice. So I started in specialty contacts, led into lots of ocular surface disease. And of course, every patient population has a lot of diabetic patients. So this um, topic is relevant for just about anyone, any type of practice, I think.
Sure, it seems like we, unfortunately, as a population, continue to grow in our diabetic patient base, and that's good for us as a profession, but obviously not as good for a clinician, as a specialty contact lens fitter as well. As I, hold that very dear, and that's kind of interesting. And so many of our dry eye patients are also experiencing, having come from diabetes. So that's very interesting. So you didn't really have a choice about this whole thing. You kind of just became a specialty contact lens fitter because it was there and needed to be taken over, it sounds
And
like.
neither yes, yes, my uncle also did some work in that space, and, I ended up, branching off, starting my own practice, building that over 15 years or so, and that's where we are now, and
Yeah,
that's
that's
my
awesome.
every day. Yep.
Yeah, so the topic that we are excited to talk about is understanding GLP a little bit more within the realm of optometrist. So, first of all, I think that there have been some practitioners who have all heard about it and have all understood it, but maybe not everybody has really a depth understanding of some of the brand names that are out there, what patients are using, and how it came about. So, could you just give us a little bit of a background of how it's being used, both on label, off label sort of thing?
Yeah, sure. So it's interesting, GLP-1s have actually been around since 2005,
Hmm.
and but really not until maybe 2020, doctors and patients are more aware, and so obviously the most popular one is semaglutide or Ozempic, and then into tirzepatide, which is Zepbound and Manjaro. And so those are all weekly injections. There's also a subset of daily pills, but they're much shorter acting and much less effective. But
Mm.
um, the ones that are most widely used are the weekly injections that do. They're extremely effective, but do have a set of side effects that patients need to overcome.
Yeah, and so what is a bit of your understanding of how this is helping in the diabetic type of patient, particularly?
Yeah, so there's drastic improvement in blood sugar, A1C, weight loss, and it is actually when you see a patient on a GLP-1 and they're actually regaining systemic health, they're being pulled off of a lot of the other medications, their insulin, their metformin, their all of the other more standard medications that they just don't need in addition to these once their system is actually functioning on a more healthy level.
Mhm. So as somebody who, knows about this more than the average optometrist and you've looked into this, what do you figure is the reason why because it seems like it's been a profound difference in our diabetic patients, particularly those that have been obese and have been really struggling to get. Why so long? Why 2005 to 2020, 15 years? Like, what do you think? Was it the cost of it, the hesitation? What do you figure is the reason why we're seemingly just seeing a surge of this so big in the last couple years?
Yeah, so I think one of the main things early on, most of those medications were much shorter acting, and GLP-1 as a hormone gets broken down in the body extremely quickly. So the newer
Mm,
GLP-1s that are out are reformulated to be longer acting. So they're much more effective, I think, than the early stage GLP-1s were. I
mhm.
also think it was the mechanism of action wasn't widely known. They knew they worked, they didn't know quite why they worked, and then if they had any potential, negative, side effects.
Yeah.
So, I
And
think it's just evolved.
there was also a period of time, if I remember from the news, where it was there was a shortage, and it was that so many people were starting to use it just for weight loss off-labely that we were concerned about it for our diabetic patients too. So, wonder if there was a supply issue as well that they weren't making it or generating it at the rate that they needed to. Did you hear anything about that?
Yeah, there was definitely and patients who really were relying on it were really upset because they finally felt like, "Hey, I have something that's working and now I can't get it." And there
Mhm,
was a multiple months in a row that patients were without their medications.
mhm.
Uh, what started to happen is ancillary weight loss clinics started compounding semaglutide, and they still do. So you can walk in as a cash pay patient and go get your weekly injections of compounded medication. And I still have patients who do that too. So if they
Mhm.
have an insurance that doesn't cover it, or maybe don't have insurance, or maybe not the right diagnosis, and you were mentioning the off-label uses. Patients who maybe aren't considered obese aren't going to qualify for it, even if they have a little bit of weight to lose.
Yeah. So for our diabetic patients, are they continuing to stay on it after they lose all this weight and it just becomes a maintenance for them and they're dropping other diabetic medications along the way?
Yeah, and that's a question that my patients ask a lot, and, it's important to talk through it with them. You shouldn't assume I'm always surprised by how little conversation patients have with their endocrinologists about this, but there's a space to educate your patients here, and
Mhm.
the idea behind this is a lifelong medication. This is an aspect of their system that is not functioning properly, and the medication will continue to be effective. It's not something that tends to wear off. So
Mhm.
normally what happens is you titrate the medication to sort of the maximum dosage to get the results that that patient needs, and then you sort of titrate back down to get the minimum to keep them stable and keep them where they need to be. But the
Yeah.
idea is never to quite completely remove it because you'll start to see the regression.
Yeah. I think, some of that confusion may come up for people because they may have heard of somebody who was on it for weight loss reasons, and they may have gone on it and then gone off of it. And so our diabetic patients are presuming that, oh, I know a friend who was on this medication. I wonder how long I'll need to be on it. And they're not realizing that it's a maintenance diabetic medication, not for them just a weight. They may lose weight, but it's not just a weight loss type of medication. So, as eye care providers, I know that even this year, I think the AOA put out a big publication, a big report on that, and I'll link that in the bio as well as your article that you wrote about this. But what are we concerned about? You said it doesn't go without some concerns, and as any medication has some side effects, and we know in the ocular side effects are there. What are we looking for and need to be cognizant of it as practitioners? But what are the side effects that we should be looking for our patients?
Yes. So the ocular side effects are worsening diabetic retinopathy, worsening macular edema, neovascular macular degeneration, and NAION. But they're only seen when the patient is already at risk, which means they already have some level of retinopathy. They might already have some macular degeneration, or they have a disc at risk. And the highest risks are for the patients who have a rapid decrease in their blood sugar or A1C. So, like, say you have a patient who is chronically at like a 9, 10, like very severe A1C, and they drop suddenly to a 6. You got to be really on top of that because the mechanism, the sudden drop in blood sugar is what causes a transient retinal hypoxia situation. And
Hmm.
it is transient, so it will level out. But in the meantime, those might be treatable or require treatment just to get them back to where they need to be.
Yeah, yeah. So you almost think that that's an exciting change because that patient's metabolically becoming a lot healthier very quickly, and that's a good thing. But we're seeing that substantial change. Um, I would presume that that has other effects elsewhere in the body to see such a huge jump like that. So, is that something that we're seeing happen, presumably less often? I'm sure it still happens once in a while, but is that something we may see happening less frequently?
I would think so because typically when a patient is started on one of these drugs, they're started at a very low level, and so they're titrated
Hmm.
up pretty slowly. But you can see the ones, and especially in the patients who were already at a moderate to severe level of retinopathy, or have some systemic implication with their diabetes already. So now you have to think about um, kidney function, and you have to think about some other aspects of what's going on in their pancreas, and pancreatitis
Hmm.
is another one of the things that can come up. So slow increases, incremental increases, and incremental decreases in A1C are kind of important for those patients.
So presumably this is something that our diabetics are seeing, and we may be seeing it in them because they already had all of these types of risk factors. So presumably, if you have a mild moderate diabetic that doesn't have retinal pathology yet, we're feeling pretty comfortable about that. Do we feel the same way when people are utilizing it off label for, for dietary effects? Are we concerned about the side effects? Because I've heard that we need to keep our eye on some things there.
We do. We can't ignore any of it, but if, we're already doing yearly dilated eye exams for diabetics. The same rule has to apply for any patient who's now on a GLP-1 who is just recently
Mhm.
getting started. So you were mentioning earlier some of the other reasons. So obstructive sleep apnea, PCOS is an off-label use, obesity's an approved use. So, just because they're not diabetic doesn't mean that these risks can't happen. But if it is in a otherwise healthy person that might not have the cardiovascular risk factors, we're going to be much less likely to see, the retinal side effects.
So when we're seeing this occurring in patients who are already at risk, how do we not know that they would have gone on to have these problems already? What is it that's making us think that it's the GLP-1 as opposed to, their diabetic retinopathy or their macular issues occurring because of the other condition? What is it that's making us realize that it's at the higher risk because of the GLP-1?
Well, I think in a patient who you're actually seeing improvement in their A1C and stabilization of their disease, you would expect the retinopathy to stabilize or improve as well. And so then
Mhm.
if they're on the GLP-1, everything else is looking great, but their retinopathy is getting worse. It's like, okay, well, we've got another factor here. And, understanding too that given a little bit of time, this should regulate, but you can't let them have full blown diabetic macular edema, in the meantime, if that's not resolving quickly enough. So that's where, sometimes that really frequent monitoring just to get them through 3 to 6 months until they really stabilize. But yeah, I think it's kind of looking at that dichotomy of, hey, they should be getting better, but they're actually getting worse, and just sort of getting them through that.
And what have you seen as the stabilization? How do we go about bringing about stability of those retinal pathologies that we're observing um, within balance of this diabetic treatment? Do we alter with their endocrinologist what's going on? And what have you heard is being done or changed or altered when these issues are arising? Are we reducing the dosage? What is being done?
Yeah, in those cases, and you never want to hinder, diabetic progress, but in those cases, you should communicate with their PCP or endocrinologist and say, hey, can we slow this down? Let's stay at this dosage, or let's maybe drop back to a lower dose for a few months, and, not necessarily purposefully worsen their A1C, but let's stop the dramatic decrease for a while and let their body sort of reach some homeostasis before you continue.
Yeah. What other things are you finding that you need to communicate with your diabetics once they're on this versus, historically what we've always talked to our diabetics about during their annuals? Do you pre-warn them of, hey, if this comes up with your endocrinologist, here's some things to consider, but also I need to be monitoring you, or how do you bring things up differently than you used to?
Yeah, so it's kind of a proactive conversation now. If they're not yet on a GLP-1 and you ask them, they're almost always going to say, well, often going to say, "Oh yeah, they mentioned maybe doing this, but I'm hesitant. I don't know if I should." And then
Mm,
good opportunity to kind of walk through what we might be looking out for, but also what some of the benefits could be. Um, and the other things that I spend a good bit of time talking to my patients about is how to mitigate just the um, the GI side effects, the
mhm.
nausea, constipation, diarrhea, all of those things. Um, they can get cramping, they can get chills. There's a lot of things that can happen there, and it can be reduced if they take the medication at a certain time and avoid certain foods. So the nausea tends to be really reduced if they do the injection at night rather than in the morning. Um,
Mhm.
if they stay extremely well hydrated, and if they avoid fatty or sugary foods for the first couple days after the injection, those are the things that seem to really trigger a lot of those just uncomfortable side effects that they can have.
Yeah, and so this is us additionally counseling of, hey, your endocrinologist recommended this. We've seen it working really well, but the worry about the side effects, and the side effects are real from what I hear, um, and it shouldn't be ignored. But that's also back to your point of why we usually titrate up, is because
Mhm.
if you went to a high dosage right away, those potential side effects could be overwhelming. Whereas when you titrate into it, um, from what I understand, is that patients do much better with the nausea maybe being the most common effect, the stomach issues that they're reporting, and so forth. Is that what you've experienced as well or heard from patients?
Yes, definitely.
Hmm.
Yeah, moving up slowly helps. I've also just heard more people tend to have more of those side effects with Ozempic than some of the others. And
Mm,
the studies don't really show that there's much difference because the symptoms are all reported across the board, but I think clinically, Ozempic is harder to tolerate. Um,
hmm.
but the other thing that I think is really important is talking to them about loss of lean mass. So they're losing
Hmm.
fat, but they're also losing muscle, especially when they've lost a lot of weight. That weight loss continues, but in muscle rather than adipose tissue. So, one of the really important things to talk about is making sure that they're doing weight training. So, you want them to walk, you want them to stay active and healthy, run if they can. But weight training is really super important to continue to maintain their muscle mass, and also taking a creatine supplement. Um,
Hmm.
and high protein diet and things like that. So they just need to be aware that, that's it doesn't mean that they can't build muscle, but they will lose it more quickly than if they weren't on the medication.
Yeah, I know that's been a major concern as healthcare providers have said. And, one of the ways I've heard it said is that you may have been carrying around, 20, 50 more pounds in the past, and you needed the additional muscle to carry that around. And now that you don't have that, your lean muscle can go down. And that's what we do not want to see happening. And
Mhm.
so, along with the weight loss, we're hoping that you feel the additional urge to get to the gym and to do some, you know, lean muscle building, but also some core muscle building as well, walking and those sort of things. And hopefully you'll feel better to be able to go do those sort of things
Yeah.
now that you've lost some of that weight. So such a key component there in recommending that. Any other thoughts that we haven't discussed for us as eye care practitioners when we're dealing with these types of patients that are on these meds?
I think we have to shift the framework. If they do have retinopathy, edema, any of those things, I think we need to start doing much more frequent follow-ups, every
Hmm.
3 to 6 months, depending on the case, until you can determine, hey, this is restabilized, their weight is stable, their retinas look stable, they seem to be in good shape. But until you get to that point, just monitoring them much more closely is important. And
Hmm.
staying connected with their PCP or endocrinologist, because we are a big piece of that loop. And patients do
Yeah.
rely on us to have these conversations.
Hmm.
Um, the other thing that I think is just really fascinating about these drugs, though, they're cardioprotective, they're neuroprotective. The new evidence coming out for dementia and Alzheimer's is fascinating. And there seems to be unlimited systemic benefits to what these medications can do.
Yeah. Yeah. Which our diabetic patients need all the help they can get, right? Everything in their body's being bombarded. Well, yeah, that is fantastic. Well, this has been awesome. I think it's been great insight into a topic that maybe eye care providers haven't really felt comfortable with because we may not be getting that systemic disease aspect of treatment for our diabetic patients. And appreciate you doing research and putting some information out there for us in the guise of articles and so forth for all the work that you've done. So I appreciate you being on the show as well.
Thank you. Thanks for having me. This was a great conversation.
Absolutely. And thank you for joining us for this episode. Make sure to like and subscribe and stay tuned next time for the OI Show.